Good morning, good afternoon, and good evening, everyone from around the globe. My name is Boris Marufov. I am an infection control practitioner from Waterloo region of Ontario, Canada, and I'm happy to present today the series of International Federation of Infection Control 2026 IPC Masterclass Series. And you can join IFIC Masterclass Series running throughout 2026 and hear global voices, infection prevention and control, share practical insights on strengthening IPC across diverse health systems. Few words about International Federation of Infection Control. It is a global federation of infection control societies and professionals working together to promote best practices, strengthen capacity, and improve health outcomes around the world. IFIC's mission is to lead global infection prevention and control by promoting evidence-based practices, strengthening educational resources, supporting collaboration across the countries, and advocating for safer healthcare everywhere. These free teleclass series, hosted by Weber Training, is open to everyone working to prevent, control, and treat infections, including professionals in infectious diseases, public health, antimicrobial resistance, patient safety, quality of care. By participating in this unique series, you will engage with experts and colleagues from around the world, share experiences, and learn practical IPC strategies, discover the benefits of becoming IFIC member. Today's session, Antibiotic Stewardship Synergy with Infection Prevention and Control to Combat AMR, the Dream Team, presented by Bradley Langford from Toronto, Canada. On your screen, you have the email where you can email your questions during the sessions. So it will be behind the scenes. We will look and collect your questions, and Q&A session will be at the end. So that email is info@webertraining.com. Please use that. Now, a few words about Brad. Brad Langford is the board certified infectious diseases pharmacist and antimicrobial stewardship pharmacist specialist at Public Health Ontario and Hotel du Chever Health and Rehabilitation Center. He is also an assistant professor at McMaster University with the Department of Health Research Methods. Evidence and Impact as an associate editor and for the Journal of Antimicrobial Stewardship and Healthcare Epidemiology. Brad's research and practice interests focus on antibiotic use and resistance surveillance, as well as the best practice in implementation of antimicrobial stewardship programs. So from here, I'll ask Brad to start presentation.
Thank you so much, Boyce, for the introduction, and thank you both for the opportunity to speak. I'm going to talk a little bit about strategies to help support antibiotic stewardship from the infection preventionist perspective. So objectives, we'll talk a little bit about antimicrobial stewardship and its importance in mitigating resistance. We'll describe the role of the infection preventionist in supporting some of the stewardship work that we do and explain the synergies between our two disciplines. We'll talk about some importance of behavioral science and improving prescribing practices, as this is something that really threads through both of our roles, and then describe some best practices in increasing public awareness about antimicrobial resistance. I probably don't have to convince this audience that antimicrobial resistance is a significant threat to public health. We know from some of the latest data on the global burden of antimicrobial resistance that the annual deaths due to antimicrobial resistance are substantial at least 1.27 million per year. directly attributable to AMR, and it's probably much higher than that when you look at the associated deaths, probably closer to about 5 million per year. In Ontario, where I live and work, there's about 6 million Ontarians who lose their lives each day due to antimicrobial resistant infections. We also know that if you have a resistant infection, compared to one that's not resistant, the odds of death are higher. So we have some data that show that if you get a bloodstream infection with a resistant organism, your odds of death are about 30% higher compared to a bloodstream infection with susceptible bacteria. So this is a significant problem, and it's here, and it's really spread globally. What makes this particularly important to focus on is that a lot of this is preventable. We know that at least 1 in 4 antibiotic prescriptions are for conditions that are generally not needed. And in some estimates are even higher than this, approaching 50% or even more. So if we can reduce this unnecessary usage, we can reduce the selective pressure on antimicrobial resistance. And that's really where stewardship comes in. So usage of antibiotics is a significant driver of antimicrobial resistance. This is an old figure, but I think it illustrates very nicely the relationship between usage and resistance. Here at the ecological level in different European countries, you can see on the x-axis the outpatient use of penicillin, and on the y-axis is penicillin non-susceptible or penicillin resistant Streptococcus pneumoniae. And you can appreciate that there's a nice linear relationship between usage and resistance, where countries that use more penicillin are more likely to see penicillin resistance in their Streptococcus pneumoniae species. This is true not only at the population level, but also in institutions, so where we work in hospitals or long-term care homes, but also in individual patients. So really the point here is that the more we use, the more we lose. So increasing usage leads to increasing resistance. And what makes antimicrobials particularly unique compared to any other drugs that we use is that the usage in one class the usage of one antimicrobial in one person can affect its outcomes in many other people. You can't really say this about other classes of drugs. Some people call this spillover effects. You can call it secondhand effects or indirect effects. But either way, this is really the effects that extend beyond the individual who receives the antibiotic. In this figure here, we outline some of those examples where there are these spillover effects. So at the top of this pyramid here, in the hospital bed, if you are admitted to a hospital bed where the person prior to you has received an antibiotic, you yourself are at higher risk of getting a C. difficile infection. Now moving down to the bottom of the pyramid here in the neighborhood level, if you live in a neighborhood where there's a lot of fluoroquinolones being used, you yourself are at higher risk of getting a fluoroquinolone resistant infection, even if you've never received a fluoroquinolone before. So this really highlights the societal obligation that we have to use these antimicrobials judiciously, because really we could potentially lose these as a therapeutic option. So a number of different countries have committed to developing antimicrobial resistant action plans to help address and mitigate this threat. In Canada, where I work, we have these 5 key pillars for action that include research and innovation, really to develop incentives to find new treatment options, new prevention options, surveillance to track antimicrobial resistance and usage over time, and develop baselines and targets. Leadership really speaks to the One Health nature of this threat, and that we need to work together among all of our disciplines and across sectors, and trying to extend globally, because one country's work internally is not going to be enough, because we know these organisms can cross borders very easily. And then at the bottom, there's the synergistic relationship that I'd like to highlight is infection prevention and control to really prevent the transmission of these organisms from person to person, and stewardship to prevent the emergence of antimicrobial resistance. And in this action plan, they've highlighted two key strategies, which is to develop guidelines and standards to ensure that we use antimicrobials appropriately, and also to foster an understanding of the risks of resistance and why it is important to use antimicrobials appropriately. So I'll talk about some of that in the coming slides. This, I think, is probably one of the best papers that shows how there is a synergy between our disciplines in infection prevention and antimicrobial stewardship. This was a study by Bauer and colleagues in 2017, where they did a systematic review and meta-analysis of 32 studies looking at over 9 million patient days. And they evaluated the outcome of infection, colonization, or both, with antimicrobial resistant organisms or C. difficile. And so they evaluated whether there was a difference in outcomes between stewardship alone versus stewardship combined with infection prevention and control measures. And what they found, I'll highlight it here, is that co-implementation of infection control measures, that's ICMs there, was associated with a greater odds of reduction of antimicrobial resistant organism infection or colonization. You can see as you add these strategies on, you're more likely to reduce the risk that these patients get infections. So I think that really highlights why both of us alone are not as effective as both of us together. And so I really think this is a dream team to prevent drug-resistant infections. We have these kind of complementary skills as well as shared skills that we work together towards a common goal, which is ultimately to prevent infections. Antimicrobial stewardship aims really to reduce overuse of antibiotics and reduce that selective pressure on patients through a number of different strategies. And a couple are listed here, like pre-authorization, post-prescription audit and feedback, which I'll chat about later, as well as tracking and reporting of antibiotic use and tracking and reporting of antibiotic resistance, often through development of antibiograms. Infection prevention and control, you all know this very well, is strategies to reduce pathogen transmission through a number of strategies such as hand hygiene, isolation precautions, environmental and equipment cleaning, as well as tracking of hospital-acquired infections. So you can see that we have some shared skills here. A lot of those skills relate to gathering, analyzing, and interpreting the data, trying to translate that data into action, and then communicating with leaders and other healthcare providers to try to influence behavior change. And so a lot of the work that we do, I'm sure you'll appreciate, is related to behavior change. A nice example of this is a study that was out of Argentina, where they looked at between the years of 2018 and 2021, where they had a problem with carbapenem resistant Enterobacterales. And they implemented a number of mitigation actions, both from the antimicrobial stewardship program as well as infection prevention team. And they were able to see a reduction in carbapenem resistant Enterobacterales during that intervention and keep that reduction stable. In this table that they published, they show some of those synergistic activities. You can see across the top several strategies of HAI surveillance, multi-drug resistant organism surveillance, hand hygiene compliance, isolation compliance, and care bundles, typically infection preventionist roles. But below that, you see some roles related to antimicrobial stewardship, like optimization of antimicrobial treatments, antimicrobial consumption measurements, and then together they work on education and feedback. So I think this really highlights that synergistic role that illustrates how working together can make a bigger difference in development of these drug-resistant organism infections. So we'll shift gears and talk a little bit more focusing on antimicrobial stewardship and give you some specific examples. This is a very simplistic definition of antimicrobial stewardship, is really to maximize the appropriate use of antibiotics now so that they currently work for each individual patient, but they continue to also work for future generations as well. And so when we think about antibiotic prescribing or antimicrobial prescribing, there's really a few key decision nodes. Some may call this the three moments of antibiotic prescribing, but they relate to initiation, selection, and duration. So the first question is probably the most important, is initiation. Does my patient actually need an antibiotic in the first place? Second is selection. If this patient does need an antibiotic, what is the most effective regimen to ensure that there's a lowest risk of harm and the patient still has an adequate drug on board? And then finally, duration of therapy. What is the shortest effective duration that we still treat the infection, um, cure the infection, but also at the same time reduce exposure, unnecessary exposure to antibiotics that could lead to resistant organism development. So it's a fairly complicated decision, and people would say, this is a largely clinical decision around, initiation, selection, and duration. But I would argue that there's a lot of other behaviors that come into play beyond just the clinical decision. And you may be familiar with this model, but I think it really helps to describe prescribing behavior. And you could probably argue it describes a lot of other behaviors that you see in infection prevention, is the COM-B model. So COM-B stands for capability, opportunity, and motivation. And historically, we focus a lot on capability. Does the clinician have the knowledge and skills to do something appropriately? In this case, do the prescribers have the information and the ability needed to prescribe antibiotics appropriately? That is only one piece of the puzzle, because we know that these other factors are at play, like opportunity. So what are some of the factors beyond the individual? What are the supports? What is the environment like that might influence decision to prescribe? For example, in the primary care setting, we hear a lot about pressure, demand from patients to prescribe an antibiotic. That extends beyond the capability of the prescriber, and now there's some external pressure to prescribe when it may not be appropriate. And then motivation speaks to the beliefs, the emotions, the analysis, and the goals of the prescriber, and how they weigh the risks versus the benefits of antibiotic use. An example here could be fear, and there's a lot of talk about fear of negative outcomes. If I don't prescribe an antibiotic, what could go wrong? And that really speaks to the risk versus benefit assessment that a prescriber may have, to think that prescribing an antibiotic is to be on the quote unquote safe side. And so that's a judgment call to say that it is safer to give an antibiotic when you're not sure than to withhold the antibiotic, and doesn't necessarily take into account the potential harms of antibiotic overuse. So it's certainly a complex decision. And if we appreciate some of these different aspects of the COM-B model, we may be more apt to design appropriate strategies to improve prescribing behavior. And so because the contexts are very different across where we may apply stewardship, we have different strategies in place. The cross-cutting strategies, I think, really persist no matter where you are. And those are shown on the bottom and the top bars here. From a leadership perspective, you certainly need policies and regulations. For example, having a requirement to ensure that there's a prescription for each antibiotic, and they're not easily available without a prescriber or a clinician assessment. Resourcing your antimicrobial stewardship programs is needed. You need human resources, technology, and data. Otherwise, this is not likely to happen. And then cross-cutting strategies across the bottom include guidelines. You need to know what appropriateness means, and prescriber and patient education, so that everyone has the same information around appropriate prescribing. And then in each of the settings, the strategies may differ a little bit. So hospital, We tend to focus a lot here on prospective audit and feedback, a strategy to review patients who are prescribed antimicrobials, usually by a trained clinician, a pharmacist, or a physician, and they review the patient, review their chart, and see if there are opportunities to optimize their therapy and make recommendations directly to the prescriber. Restricting broader spectrum antibiotics relates to ensuring that these reserved antibiotics or broader spectrum antibiotics are only used when absolutely needed. And then in long-term care, the strategies may be a little bit different. The resources are less, and there's some challenges that are more common. Over-culturing of the urine is particularly common, long durations of therapy, and so there's opportunity for multifaceted strategies to address both of these issues. And in the community, some strategies that have worked well, and I'll talk about, I'll focus on the first, is peer comparison feedback reporting. But there's other strategies that have been used, like commitment posters that go up in the waiting room that are signed by clinicians with the photo of the clinician saying, I pledge to use antibiotics judiciously in order to protect my patients and the population. And antibiotic amnesty is also another strategy whereby leftover antibiotics are taken in by the pharmacy and not disposed of, through the landfill or into the sewage system to reduce environmental exposure. So let's dive into some of these different strategies, starting with the hospital setting first. In Canada, we've had a accreditation requirement since 2013 that says that if you are a hospital and you want to be accredited, which is the vast majority of hospitals, you have to have an antimicrobial stewardship program in place. This is called a required organizational practice. And so you can see over time, the number of hospitals that say they have a program has drastically increased from in the 30s to close to the 90 percentile or 90%. And it's kind of held steady across time. But this only tells you part of the story. Certainly, these hospitals are now meeting criteria largely for accreditation requirements, but that doesn't speak to the variability within those programs. How intense is your program? Are you actually able to make a difference in antimicrobial prescribing? So one of the strategies I talked about that is often applied in hospital settings is prospective audit and feedback. And this is a study that we published a few years back that looked at the recommendations that we made to prescribers over time. We made over 11,000 stewardship recommendations to the prescriber, and 82% of them were accepted, which is kind of along standards of general acceptance that we've seen in the literature. But what's interesting is that the different recommendations are not equally likely to be accepted. We found that recommendations that aim to increase the exposure of antibiotics, like we recommend to start an antibiotic, to increase the duration, or to broaden or escalate the spectrum, clinicians are much more likely to accept those. On the other hand, if we recommend to stop antibiotics, shorten the duration, or de-escalate or narrow the spectrum, you can see that there's a lower odds of acceptance, which I think is interesting and suggests that, there's this underlying belief that more is better than less from an antibiotic perspective. And so we have some work to do to ensure that there's a bit of a recalibration in what we think to be considered safe when using antibiotics judiciously. I spoke a little bit about intensity here, and this is one value effective audit and feedback programs in hospitals and varying different intensities of those programs. And so what we did was we evaluated over time changes delivered the prospective audit and feedback.
Looks like we lost.
I think I'm back.
Oh,
I'm
he's back.
back now.
Okay, good.
Okay.
Yeah, great. Thank you.
Okay, thanks. So perspective audit and feedback is to make recommendations directly to the prescriber to optimize antibiotic use. And here we have, focused only on targeted antibiotics. So drugs that were broader in spectrum, and we did one-to-one the recommendations from the pharmacist directly to the prescriber, typically over the phone. And then we switched to a more high intensity approach where we focused on all antibiotics. We included lots of people. So the pharmacist who was making the recommendation, the pharmacist on the ward, the stewardship physician, as well as an intern, so that we're all kind of on the same page when making those recommendations. And we found that that higher intensity approach led to lower overall antibiotic use, the lower targeted antibiotic use, and no changes in clinical outcomes. Another strategy that I think many hospitals are now looking at as they modernize their electronic health record is how to use clinical computerized decision support to nudge clinicians towards more appropriate antibiotic prescribing. Here I've listed a few examples of what that might look like in the electronic health record. Things like requiring that the clinician documents the indication for antibiotic prescribing and urine culturing. So we need to know why you've prescribed that antibiotic so that everyone's clear, everyone's on the same page, and that can facilitate audit and feedback as well. Requiring and recommending standard durations for antibiotic orders. So not leaving those durations of therapy open-ended, but having them linked to the indication so that they're appropriate and having them reassessed early so that they don't go on unnecessarily long. Incorporating guidance into the electronic health record can be really helpful through order sets, for example, trying to focus on your high yield conditions like your UTIs, like your pneumonias or skin and soft tissue infections. Those can address some of your local challenges and ensure that clinicians are aligned with some of the best practices. One of the more advanced approaches is to provide patient-specific prompts at the time of prescribing. And I'd like to highlight a study that has done this particularly well. This was the INSPIRE randomized controlled trials by Shruti Gohil and colleagues. This is a series of cluster random controlled trials where they implemented computerized physician order entry bundles and basically at the CPAted to the prescriber whether the patient had a high or low risk of multi-drug resistant organisms. This information was provided just at the right time because they're about to prescribe an antibiotic. In many cases, it's a broad spectrum antibiotic, but the bundle would tell them, hey, you actually have a patient who's very low risk of multi-drug. I see that I've lost, but I'm shouldn't bear me.
Yes, yeah.
Okay, thanks. This system was able to recommend using narrower spectrum when appropriate, and in the nick of time, data around recommending narrower spectrum therapy with broad spectrum prescribing. In this study, this was urinary tract infections, percent reduction in broad spectrum days of therapy, but a number of other conditions, including pneumonia, skin abdominal infections, and also saw some reductions in prescribing there as well. Are you still able to hear me?
Yes, but
It's showing that lost connection every few minutes, but I'm glad you're still connected. So in order to address some, we need the staffing and the resources to do that. And so this is a particular challenge across the globe in both high and low income countries. But even in high income countries like Canada and the US, we don't have the staffing that's really required to do our best from a stewardship perspective. This is some data from uh, Ontario, where we looked at the stewardship staffing for pharmacists. Pharmacists are shown in purple, and in blue is the physicians. And the red dotted line represents the recommended staffing levels for both physicians and pharmacists. And you can see we're not meeting those targets. We're getting kind of close with large community, but overall we're well below what we need to be to hit those targets and to really do our best from a stewardship perspective. So we have some work to do. In order to address this, there's some work that's underway to make recommendations around appropriate staffing for stewardship programs. I know that the American Infection Control Society has addressed this as well, and they have a staffing calculator. So we're hoping to do something similar for antimicrobial stewardship, to identify what those key activities are from a stewardship perspective and develop a user-friendly web-based calculator that can be customized for different institutions and recommend, okay, this is what you need to staff your program and to make a difference in terms of appropriate antibiotic use. And then we want to leverage implementation science to make sure that these recommendations actually make it to the front line and improve staffing levels. So we're hoping that this is going to be launched towards the end of this year. So keep your eye out for this. Some work funded by the Society of Infectious Disease Pharmacists. It has recommendations, though, not just for pharmacists, but also physicians, as well as other supporting staff in antimicrobial stewardship programs. Long-term care is another interesting area from an antimicrobial stewardship perspective. So in Canada and the US, this is where a lot of older adults who receive a fairly large amount of antimicrobials over time. And many of these antimicrobial prescriptions are unnecessary. We see significant variability in antimicrobial use. These bars here in this chart show individual and long-term care homes. There's over 600 of them in Ontario. And the y-axis shows the antibiotic use per 1,000 resident days across these different homes. Here you can see the vast variability between homes, from the left side around 20 antibiotic use days per 1,000 resident days to the right side around 200 antibiotic use days. So a variation, a range of tenfold, which suggests there's unnecessary usage going on. In this study, they grouped the homes into low, medium, and high usage homes just by looking at the tertiles, and they evaluated, is there a difference of being in a high antibiotic use facility compared to a low antibiotic use facility in terms of the negative outcomes or the harms associated with antibiotic use. They looked at composite outcomes. So the composite outcome was a combination of C. difficile, diarrhea, antibiotic-resistant organisms, antibiotic allergies, medication adverse events, and then a combination of all of those. And what they found that is, if you're a resident in one of those high usage facilities, you had a 24% greater risk of having this composite outcome of harm than compared to if you were in a lower usage facility. So this really showcases that secondhand effect issue, in that it doesn't really matter if you're the one receiving the antibiotics or not. If you're in one of those facilities, you're more likely to experience harm. Of this overuse in long-term care home is some long courses of therapy. We're learning from lots of recent data, pretty high quality randomized controlled trials, that shorter is smarter. There's a lot of data that show for many common infections, that we see in our older adults, that we can use shorter courses of therapy. They tend to be equivalent in terms of their effectiveness, but they also reduce the risk of side effects and resistance for our patients. And so this takes some time to get into practice, and not everyone's prescribing these shorter courses of therapy. So there's an opportunity to make an impact on this prescribing. We did a study to look at the daily harms associated with antibiotic use, and we did an umbrella review, which is basically a review of reviews, where we looked at 35 systematic reviews that included 71 short versus long duration trials that included over 23,000 patients. The outcome that they looked at the most commonly was adverse effects. And they found that for each additional day of therapy, there's about a 4% increase in odds of adverse events. And so that indicates that each day counts, each day makes a difference. And when you think about some of the decisions you make around prescribing duration, for example, 5 versus 3 days, that's a 9% increased odds if you use a 5-day course of adverse events. 7 versus 3 is a 19% increase odds. So sometimes you will have conversations with prescribers and they'll say, well, they're only on day 4 of 5 or day 4 of 7. Even though they're feeling better, let's just continue the course just to be safe. But I think, we can use some of these data to argue that actually it's to be safe if we shorten the duration and reduce the unnecessary exposure, because there's a risk for each additional day that we give that patient an antibiotic. So to help support some of these decisions around duration of therapy, we developed some fact sheets that are available on our website. These include the most common conditions that are seen in long-term care and the recommended durations of therapy for cystitis, cellulitis, and pneumonia. We accompany these with evidence briefs to explain how we came up with those durations of therapy and how there's actually really decent amount of data to support these recommendations, as well as a fact sheet that explains some of the misconceptions around antibiotic duration, and that shorter therapy tends to be smarter from the perspective of side effects, C. difficile, and antimicrobial resistance. Another particular problem in long-term care that often extends in other settings as well is overculturing of the urine. We see this a lot where patients have, especially older adults, have nonspecific symptoms that are often attributed to urinary tract infection. Sometimes these are like smelly or cloudy urine, or that the resident has confusion alone, or they've had some recent falls. And so they send a urine culture just to check. And often in these older adults, it's very likely that they have colonization of the urine with bacteria. So the urine culture ends up being positive. And as a result, they receive antibiotic treatment. And then there's downstream impact, including antibiotic harms. Things like C. difficile, antibiotic resistance, and possibly even more UTIs, because you're selecting out more resistant immunogenic organisms by giving them antibiotics. So to address this, probably we've developed these virtual learning collaboratives that help to reduce urine culturing and reduce antibiotic prescribing. And this we enrolled over 100 different homes, and applied a number of strategies, including education of staff members, education of patient and family, develop calls to help reduce unnecessary urine culturing. And we found when we enrolled to those that were not enrolled, we saw culturing a reduction in antibiotic prescribing, as well as no signs of undertreatment of urinary tract infection. So to the community setting, which is kind of a newer area for antimicrobial stewardship, antibiotics tend to be prescribed here. One of the main things that we need to help support appropriate antibiotic prescribing in outpatient settings is to have guidelines so that people know, okay, we're all on the same page. What is considered appropriate use? In Canada, we've just released, and we're quite proud of these guidelines that we've came to a consensus on what appropriate is for common respiratory tract infections, and we're moving on to other infections like skin and soft tissue and urinary tract infections. These are free of charge, available on an app called First Line for anyone to use. But having the guidelines is not enough. There's certainly other things that we need to do, including giving feedback to prescribers. This is an example of a study where we mailed out to individual physicians. Over 4,000 physicians received a letter that tell them how they prescribe compared to their peers, including the number of antibiotics they prescribe, how long they prescribe for compared to their peers, and give them some education and strategies to improve. We found that this resulted in a reduction in overall prescribing, a reduction in unnecessary long duration prescribing, as well as broad spectrum usage. And what we found is particularly interesting is that not only does reduction in antibiotic, particularly cost effective. This was just actually published. It says under review here, but it was just published 2 days ago in JAMA Network Open. And we show that there's a cost benefit to this strategy because you get about $9 back for every dollar that you spent in these letters. You know, there is some cost to put these letters together, some analyst time and the mailing costs, but there's cost savings related to antibiotic use, as well as the downstream effects of unnecessary use, like side effects. Diarrhea was a big one, where we can reduce diarrhea by improving the appropriateness of antibiotic prescribing. So this is something we hope to encourage others to do, as well as locally, to increase the amount of feedback that we give to prescribers to improve antibiotic prescribing. To help support some of the patient demand requests that we hear from physicians is this viral prescribing pad. This is something that we can give to patients who may be requesting antibiotics. It validates the concern that, you know, in fact, you do have an infection, but it gives them some supportive care recommendations rather than giving them an antibiotic. This is particularly helpful for upper respiratory tract infections that don't need antibiotics. And you can say, okay, here are some things that you can do to feel better, validates their concern and redirects them to focus on some supportive care strategies like analgesics and saline nasal spray, etc. We've done the same thing through these resources that are kind of like shared decision-making resources for common respiratory tract infections. Here's an example for bronchitis, where we give some information that clinicians and patients can have a discussion about. You know, for example, bronchitis is typically caused by viruses, so antibiotics don't work against them. The color of your phlegm and your sputum doesn't really make a difference, doesn't tell you if it's bacterial that well. And if you take an antibiotic, you're not any more likely to feel better quickly, but you're at higher risk of harm, such as nausea, vomiting, headache, and diarrhea. So we recommend there's other things that you can do to feel better. And here are some things that you can watch out for or when to seek help and follow up. We've done the same thing with sore throat, sinus infection, and ear infection. And this has generated a lot of interest. So it has been translated into other languages like Spanish and Chinese. So from the public perspective, I think we have some work to do to communicate about antimicrobial resistance. It has a bit of a language problem. It's not super clear when we say AMR what that means from a general public perspective. Very few of the public have even heard of antimicrobial resistance. And once you explain it to them, they don't necessarily perceive it to be an urgent threat. About 76% of respondents, which is a very high number, believe that antibiotic resistance happens in the body. So it's you that become resistant rather than the microbes, which is an important misconception because if you don't understand that the microbes become resistant, then you don't necessarily understand the transmission, how these can move from person to person and affect your family and friends. And also, people don't tend to believe that there's much that one can do about resistance, which is obviously not true because there's lots of strategies that the general public can do to reduce this. AMR resistance campaigns are becoming increasingly common, but many of them haven't really been studied, so we don't know exactly how well they work. Of those that have been studied, there's probably a few key components that tend to work best. Things like focusing on key messages. So targeting a specific condition, particularly upper respiratory tract infections, can be an effective approach. Addressing both the demand side, so the patient, as well as the supply side, so the prescriber, so you kind of coming at it from both different angles. Using active approaches in addition to passive approaches, so having active educational modules and face-to-face learning like we're doing now, but in addition to that, having mass media and patient handouts available. And pairing this with co-interventions. We know awareness is not enough. We have to do something more active. So things like audit and feedback that I talked about, clinical decision support, communication strategies can help to improve the effectiveness of these awareness campaigns. Some really great work that has been done out of the Wellcome Trust talks about some of the 5 messages that we should be speaking on to communicate AMR to the general public. This includes framing resistance as undermining modern medicine. So talking about some of um, the key infections that people may experience that could actually become much more dangerous if AMR was to be at play. For example, having a hip replacement, prophylaxis for hip replacement, or treating a UTI or pneumonia. Explaining the fundamentals succinctly, that antibiotic resistance happens in the microbes and these can pass on from person to person. Emphasize that this is a universal issue, affects everyone, including you. So sometimes using patient individual stories can be helpful to make it more resonant that this is something that can actually happen to you. Focusing on the here and now. So we often focus on, by 2050, there's going to be X million number of deaths. That is certainly alarming, but it doesn't really resonate with the individual. So you can talk about how this is actually affecting people right now. And then encouraging immediate action, things we can do right now to feel better without antibiotics, like what's in the viral prescribing pad. Some really great work out of the UK from Eva Krakow talks about what we should say versus shouldn't say when communicating AMR to the public. Interestingly, the term AMR or antimicrobial resistance doesn't really resonate, but things like drug-resistant infections or antibiotic resistance are more clear. Certainly using simple language can be helpful, highlighting the personal risks that I talked about earlier, and promoting motivation rather than lingering on apocalyptic languages can help make people feel that they're empowered to make a change to reduce AMR. We've embodied some of these principles in a Canadian awareness campaign called AMR Aware Canada. This has some nice shareables that are available for the public and healthcare professionals, some resources and tools that we vetted and selected, stories from patients and providers, as well as a webinar series. So you're more than welcome to check that out and sign up for the mailing list to receive some of those resources. In Canada and globally, during World AMR Awareness Week in November, we have a Go Blue for AMR campaign, and we encourage other countries to participate as well. This was started by the WHO to kind of bring visibility to antimicrobial resistance, knowing that this is an invisible threat and many people don't really appreciate the potential impact. So we do this color campaign where we try to wear light blue during the week. We use blue on our social media profiles and backgrounds. We have landmarks across the country that light up in blue. And we just tend to try to share as much as possible about why we've gone blue for AMR. One thing I like to share to kind of spread the message is a personality quiz that I've developed alongside with some other colleagues, where you answer a series of questions about yourself, and then it tells you what antibiotic best matches your personality. It's fun, but it also has some educational opportunities and links to useful resources, and people tend to like to share it. And we find that it tends to go beyond, just us healthcare professionals or experts, and others start to see it, like students or other healthcare professions who are not in infectious diseases. So I think a nice resource to start spreading the message. So in conclusion, I hope I've convinced you that AMR is a significant public health threat, and it really requires that all of us have our hands on deck. There's lots of synergistic opportunities between our roles to reduce the emergence and transmission of drug-resistant infections. And some clear opportunities for collaboration include, but are certainly not limited to, some of these multifaceted strategies to mitigate AROs and C. diff, like working together on protocols, sharing data, influencing prescriber behavior. We can also work together on collating our data, AMR and ARO metrics and CDI metrics, and contributing to some of these local, regional, and national AMR awareness efforts. So I'm going to stop there, and hopefully we have some time for questions, and I'll turn it back to Boyce.
Oh, wow. Wonderful. Thank you very much, Brad. So it was so much information, very insightful, and I hope it will be some good tips and resources to use from here. And we have some time for questions. And so far, let me read one from audience sent to the email. And that question is, how would we find out about the Spark calculator? Is that the website, or how people can access that in the future? You said it will be available.
Yeah, it's not yet available, but we're hoping by the end of 2026, we'll have a calculator that's freely available for usage. One area I would keep an eye on is the Society of Infectious Diseases Pharmacists, or SIDP. They will likely be the ones that post the calculator. But if you're interested in participating in some of this work, you can reach out to me. These email addresses, either of the email addresses here, and I can share some more information. But as of now, this is just work in progress, and we're still developing the calculator.
Okay, excellent. So yeah, please, if anyone interested to ask some additional questions after the session, even there are emails in front of you on the screen. So please email Brad. He will be happy to respond. And so another question I have is, what is the biggest challenge in the implementation of antimicrobial stewardship and collaboration with IPAC team at the organizational level? And also another question I had is, what are the higher level, like we can see that you've implemented quite a few things at the provincial level in Ontario, Canada. So what are the hurdles or challenges at provincial or state or country level to implement, to start with the organizational level challenges?
Yeah, I think one challenge that kind of threads through, whether it be local or regional, is the availability of resources to staff your program. Certainly, we have lots of great ideas on what works, and there's good evidence. We have guidelines from the Infectious Disease Society of America, what you should be doing with your stewardship program. Like, you should have perspective audit and feedback as an example. But we know that not all programs are able to see every single patient that they have who's on antimicrobials, which would, in theory, be ideal. And so I think resourcing your programs is probably one of the biggest challenges that we have. There's certainly variability, and we're currently looking at this right now to see what is that variability in staffing of stewardship programs. Some of them have tons of FTEs, and they're able to see most patients and do lots with their program, and others are not quite as well staffed. So we're hoping that that staffing calculator helps. There's also some work coming out of the Infectious Disease Society of America that will provide staffing recommendations on stewardship programs. I suspect this is, probably a similar issue with infection prevention and control, but they may be a little bit further ahead than us. And so staffing tends to be pulled from different waxes and wanes, lots of turnover amongst our positions. So the capacity to do stewardship is probably another issue, or we have lots of new people in their role and they're still learning to do stewardship. So there's lots of good resources, some free resources out there for stewardship program development. But I think, it kind of goes back to, like, do you actually have the staff to learn and to build that capacity?
Okay, sounds good. Thank you. And let me see in the chat. We don't have any more questions. So if I can move on to the next slide and say that before that, thank you very much, Brad, for the excellent presentation. It was very insightful, and yeah, we're happy to have you as a starter at the beginning of the series of IFIC ICP Masterclass Series 2026, and we will appreciate your future collaboration with us. Okay,
Thanks for having
now,
me.
thank you. What you have in front of you is the IFIC barcode, QR code to the website. You can go in and learn. So this session was presented by IFIC, the Global Federation of Infection Control Societies and Professionals, working together to promote best practices, strengthen capacity, improve health outcomes around the world. IFIC connects societies and professionals across the world, supporting them with international conferences and events, educational resources and training materials, global collaboration and networking opportunities, support for emerging and developing programs. And joining IFIC means being part of the global network, working to advance infection prevention and control standards across the world. IFIC membership connects you to the global network of ICP societies, experts, and resources. Full membership available to societies and associations and organizations worldwide. Individual membership is open for professionals involved or interested in infection prevention and control, and explore educational resources, including the basic concept of infection control, expert publications, the Paul Weber teleclass we started together now, created to strengthen infection prevention and control practices. So this IFIC series for upcoming sessions, you see 3 subjects throughout the year. We'll bring leading infection prevention and control experts together for 1-hour session. Join thousands of healthcare professionals worldwide. Mark your calendars and join these upcoming sessions, but these are the 3 first, and they will be continued throughout the year until end of the year. So I also want to talk about other upcoming sessions in the Weber teleclass. You can see from the webertraining.com website. There are lots of interesting sessions happening. And at the end, I want to also thank the teleclass educators and sponsors, educational sponsors, Diversey, Virox, and Gamma Healthcare. And without their help, I won't be able to broadcast to you guys. With that, just checking, no emails with questions. I can conclude today's session and have a good rest of the day. And please join us for next upcoming series. Thank you very much.